I feel like today's episode is so appropriate for when this releases at the beginning of January because we all have been there. New year, new me. You know, in previous episodes, we've talked about the 6,000 calories you probably consumed on Christmas Day. And now you have to pay the piper now that the new year has started. And, you know, it's actually a really important topic because as of 2023, the obesity rate for adults in the United States was roughly 40%.
Wow,
That's a staggering number.
it is.
And it's not surprising that people are looking for all kinds of options for weight loss. You know, in our previous episodes, we've talked about diet, lifestyle modification, and medications for weight loss. Today, we're going to discuss some of the surgical options for weight loss with one of our great local surgeons, Dr. Adam Purtell. Dr. Purtell is board certified in general surgery and fellowship trained in bariatric surgery. He's one of the directors of West Texas Bariatrics here in Lubbock and is adjunct faculty at Texas Tech Health Science Center. By the end of this episode, we hope we've answered your questions about the types of surgical options that are out there, success rates, complication rates, and what to expect with life after surgery, and also how surgeons decide which option may be best for you.
In the second half of today's episode, we are discussing an interesting, often overlooked topic, obstructive sleep apnea, which actually I think has a little bit of a tie-in to what we were talking about the first half. So this is great.
Absolutely. We're your hosts, Dr. Cari Sorrell
and Dr. Jessica Gray.
Welcome to the MedEdit podcast.
Toss endless online searching to the curb. Let us edit out the noise and bring you medicine without misinformation. Welcome to the MedEdit podcast.
So, you know, we have had a lot of patients in common in the past, and especially with what I've seen in clinic, which has now been renamed. So we're now calling metabolic dysfunction associated steatohepatitis, or MASH, which used to be NASH. And so we've discussed bariatric surgery quite a bit. So let's start off with explaining to our listeners what bariatric or weight loss surgery is.
Sure, that's a great place to start. So weight loss surgery or bariatric surgery is primarily a operation that is an elective surgery. In other words, we're planning this in the future as a controlled setting where we're changing the anatomy of your GI tract in order to lose weight. And so that's primarily probably most achieved by two functions. One is restriction. So we're making the stomach smaller. We're making the surface area of the intestines less available for absorption. The second would be more of a hormonal control, and it offers both, but it's a surgery that's ultimately a goal is to lose weight and maintain weight loss over a long period of time. And so for our patients, what I tell them is it's going to change your life. It's like it's a permanent surgery, right? So you can't have this operation and go back. But the benefits, the majority of the times, once we kind of go through them with them, it's worth the risk.
I love that. And so you just mentioned that briefly there, and I think a lot of the patients think that the benefits of bariatric surgery are just that anatomical modification, like you were talking about.
Mm-hmm.
But then you also hit on this with like the hormonal responses. We're talking about how it can reduce the hunger signals that travel from your digestive tract to the brain, right?
Correct. So, you know, there's a couple of philosophies on that, but I think probably the simplest way to think about that is there are some hormones produced in the stomach, probably primarily in the fundus of the stomach, which is kind of that top part, that rounded part. And the one that we always hear about is ghrelin, which is an appetite stimulant. And so when we remove that from the GI tract, whether it be actually removing it or bypassing it, you know, so sometimes we actually take that part of the stomach out, or in particular surgery, sometimes we just bypass it from where the food travels. Either way, when you take that ghrelin out, it tends to drive the hunger or the appetites down. And so basically the hormones are not telling the brain that you're as hungry as often. Now that's not going to tell a patient, hey, you're not going to ever be hungry. It's not like you're going to have this surgery and you're never going to be hungry. Or, you know, if you don't eat all day, you're going to have appetites, obviously. But it does help kind of control that. And I've heard it described as this, and I think it's a good way to describe it, is like food noise. You know, when you're walking through the fridge, you're walking through the kitchen, you're like, that kind of looks good, I'm gonna have that. Or you're sitting there and you're thinking, maybe I'll just go grab that out of the refrigerator. That noise, it takes that away. You don't think that way, and so it is helpful from that standpoint. I think it's also important to think about it is that hormonal control potentially is a long-term control. And so if you continue to change your lifestyle habits, in other words, control your portions, for the most part, make good choices as you move along through the years after your weight loss surgery. You can contain or maintain that appetite suppression to some degree, and it's different for every patient. But it is a real thing. And most patients describe it as, I just don't think about eating as often. I don't feel the same way about eating. It may not give me the same gratification as it used to. But whatever degree it is, they do have some of it. Okay. And it may not happen immediately. It may happen over a period of time after your surgery. Um, but it is an important component of these operations.
I think that's really important too, because you said that not everybody's the same, but it's important to mention this weight loss surgery isn't a quick fix. And so it takes a lot to go into it. I have a lot of patients that we've referred over, even to your group, where it's a process. And I think I have so much respect that it is a process, right? They have to meet with different specialists on a team. It's not just, hey, sign up for surgery, let's book you for the next week. It requires preparation beforehand and just really a long-term lifestyle change, not being on a diet, but a lifestyle change afterwards to be successful. So when do you consider bariatric surgery as a reasonable option for a patient, or what may qualify them for surgery?
So we have specific standards that patients have to meet to qualify for surgery, and those have been set by our boards. We have what's called the ASMBS, which is it's our boards for weight loss surgery. And so they set a standard, and it's based primarily on BMIs and comorbidities or medical problems. So actually, in 2022, they changed those numbers. So historically, the BMI had to be 35 or greater. The newer recommendations, and this is based on research, both on outcomes, how well patients have done, but also from the safety perspective, how safe these operations are. So they've made it now more available. And so the new recommendation is anybody with a BMI of 35 or greater is a candidate for weight loss surgery, regardless of any medical problems. So they don't have to have any other medical condition. If their BMI is between 30 and 35, then they may require a medical comorbidity or have failed some sort of weight loss plan, program, something along those lines. So it has changed. In other words, it's allowed for more people to qualify for the weight loss surgery. Now, from a you know common sense perspective, I don't know how long it'll take the insurance companies to buy into this new recommendation, because now they're looking at paying for more operations potentially. But from a patient's health and wellness perspective, it's a great thing, because they also, in that same presentation or that same discussion 2 years ago, they also discussed how much the safety or the outcomes have improved. So simultaneously, you're able to offer the operation to more people because it is safer, but it is very effective. And so I think really, it's a huge number of people who are available for the weight loss surgery. I think sometimes the issue is, one, it's either never offered to them, or maybe a consideration that they might even have considered. And so we only see about, it's less, about 1% of the population that's available for the surgery actually gets it in a given year. So it's something that we're kind of working on.
That's really interesting. And I definitely remember being in medical school and it was just getting more popular, and people started using it. And everyone was very nervous about suggesting it to patients. And I do believe that I saw a few complications in, the hospital from some of these surgeries as well. And it just seems like it hasn't had, outcomes like you've been saying are so much improved. There's all these different options. I feel like these surgeons are much more willing to do surgery on some of these, not necessarily low, but obviously lower BMIs, especially ones with a lot of comorbidities. And when you mention the comorbidities, ones as a primary care doctor, I always think of, or, like the hypertension, the diabetes, the obstructive sleep apnea. Are there any other comorbidities that put somebody into that qualifying category?
Oh, it's a long list. The common ones, like you mentioned, are the ones the majority of the people have or struggle with. Cari actually mentioned a very common one too that people don't think about a lot, is that NASH or fatty liver.
Mm-hmm.
And so as far as very quickly becoming one of probably the second leading cause of liver failure in the country, is fatty liver. Um, any kind of insulin resistant disease process like diabetes, PCOS, those types of things are managed with this. Also, joint problems, back, knees, ankles, a lot of that's just a physics issue. So if we can get the weight off of people, the limitation on their ability to exercise and move around goes away, because if we can get the weight off and make the joints feel better, then they can be more active. And so for me, sometimes the more exciting things are not the tangible blood pressures or the diabetes, but it's the stories about people, hey, I can go do this with my grandkids that I wasn't able to do before. And sometimes those are things that are just as exciting, or from a life's perspective, as important to that patient as, hey, I don't have to take my blood pressure medication anymore. So uh, I think that overall, yes, the comorbidities are there, and I got statistics I can show people all day. From a health perspective, other than maybe stopping smoking or something along those lines, I don't know if there's much more you can do for your health than losing weight and keeping it off long term. And the surgery offers that probably at a higher percentage than any other thing we can offer. And so from that standpoint, it's just far and above, you know, offering extended life potential to people.
Absolutely. Absolutely. I agree. And, it's interesting because as Jess mentioned, when we first started out training, I feel like lap band was like kind of,
Yeah.
the only thing, or that was the most popular thing at the time.
Right.
And I still see quite a bit of that and see some complications from that in my practice, and it's funny because they'll start talking about symptoms. The first thing I'll ask is like, so you had a lap band? Still there? That's always the second
Yep.
question. But what are some of the more common types of weight loss surgery that we're doing now? And how do you decide kind of which one is the best for which patients?
Sure. So definitely, I think the key there is, one, you mentioned per patient. I think you got to look at patients as an individual. And so we try not to put everybody into one broad category. But from a safety perspective, one of the smart things that our boards did was they limited the number of operations that they say you're supposed to do. And so basically, they've got about 5. And the reason they do that is because they want a standard set of operations that have been done and vetted. And so we know they work and we know they are safe. It also keeps people from trying crazy things. And
Mhm.
so I think for weight loss surgery, one of the big problems about 20 or 30 years ago, when it was starting to become kind of a growing practice, is that you had a lot of people doing things that were outside the norm. But there was no standard because we really didn't have bariatric surgery back then. So people were trying this variety of things. So you have one surgeon who's doing good operations, good outcomes, but then you may have another surgeon in another location who has a lot of bad outcomes, and you put it all together, and bariatric surgery looked really bad, 30 years ago. So by standardizing it, in other words, by saying, hey, you can only do these set operations, y'all focus on these because they work and they're safe. That is very helpful, I think. So the operations that we primarily do nowadays, the lap band is kind of fallen out of favor to some degree. And it's primarily because, one, it doesn't have the weight loss profile the other ones offer. For me, the biggest reason I don't like to do the lap band anymore is the failure rate. And so about some studies suggest about half to 60% of them have to have a second operation. So as a surgeon, it's hard to offer a surgery that says, hey, there's a 50% chance we have to do something else. I don't like that plan. So we don't do those anymore. We do take a bunch of them out. So we take them out and we usually do another operation. So the other ones that we do most commonly are what's called the sleeve gastrectomy, the gastric bypass, and then there's one called a duodenal switch, or we call it a SADI. They're very similar operations, but if you look them up, that's what it's described as, is a SADI or a duodenal switch. And those are all kind of in increasing aggressiveness. Probably I would say that the sleeve is a little bit more conservative, the bypass slightly more aggressive, and then the SADI or the duodenal switch most aggressive. All are good operations. As far as choosing it on an individual level, it kind of depends on patients' BMIs, comorbidities, other medical conditions or medications that they take. Um, and those are individual discussions that we have with them. But I think the best thing kind of to do first is to have a patient just be interested in the surgeries, and then we can kind of work to which operation they want to get to, I think.
Now, many people in general just fear surgery, for maybe some reasons are out of proportion than they maybe should be, and some are very valid. You have to be put to sleep. Someone is cutting on you. It's understandable. But how are most weight loss surgeries completed these days? How do we kind of assuage some of their fears or kind of address some of these concerns they may have?
So that's a really great question because I feel like for weight loss surgery, the biggest thing we fight a lot of times is this, you could call it a myth or maybe this idea that weight loss surgery is some very scary, unsafe operation or that surgery outcomes are bad. If you look at the statistics, today weight loss surgery is as safe as taking out your appendix, doing a gallbladder, doing a hernia. There's actually a really good study recently that compared these things. And so they looked at common operations. They looked at a sleeve and they compared it to gallbladders, inguinal hernias, and appendectomies. And really, the only variation between the four that they could show, as far as risks were concerned, was some increased lengths of stay for the sleeve compared to some of those operations. Otherwise, it was equivalent in risk of morbidities and mortalities. So the other thing about the weight loss surgeries, other numbers to look at is your risk of a really severe complication after weight loss surgery is 4% or less, depending on which study you look at. So that's comparative to other very common operations we do: gallbladders, hernias, appendectomies, etc. Um, so I think to assuage people's fears, things have changed, I guess. So it's not what it used to be as far as the outcomes and why people 20 or 30 years ago, I could understand the concern. A lot of people have a neighbor, an aunt, they say, hey, they had this surgery and they had a lot of problems. And y'all have seen them in your practice. We've all had those experiences. And I'm not saying we're perfect now. We still have complications. I think we've just figured out how to do things much better. And that's made the complications very, very rare. Okay. What major complications in our procedures or could be considered 1 to 2% or less in most cases, depending on the patient, but unless they had some increased risk for some other reason.
Yeah. And I know you mentioned surgery is getting better. I know you guys do a lot of these laparoscopically now,
Mm-hmm.
which people don't know what that means. Basically, it's small, tiny cuts. Instead of, I think a lot of people are fear they're going to just cut, all the way down, some big
Sure.
incision. And that's not really the case anymore. And I think that affects the recovery as well that people worry about.
Certainly. One of the reasons the surgeries have gotten safer, recoveries are easier, it's not because we're necessarily better surgeons. The technology has gotten a lot better too. And so what we have at our disposal now is we do a lot of minimally invasive, yes, laparoscopic with the small incisions. And actually, we've started incorporating in the last 4 to 5 years a lot of robotic surgery into our practice. And so what that offers the patient is, again, small incisions, same day surgeries. A lot of times these patients will go home on the same day after their operation. If not, 95, 98% of them go home the next day after the operation. But the robotic surgery itself and the stapler on the robot, I find is just superior. And the outcomes that we're having are even better than they were before. I felt like our outcomes were good before. Now I feel like they're even better. And so it's exciting to see that. And as a surgeon, I really enjoy that because there's less stress and patients are doing great and it's fun to see. But um, that recovery for patients comparative to say 20 or 30 years ago that those guys were having more problems, they were doing big incisions on these patients and they were staying in the hospital. That leads to blood clots and pneumonias and various other complications from laying in bed for several days. We don't have to worry about those things. So the technology has helped us a lot as well. We definitely use the minimally invasive approach, uh, which has made the patient's recovery so much easier.
Absolutely. Yeah. The recovery has been pretty impressive from what I've seen in the last few years. Like you said, comparable to kind of what we consider standard surgeries, gallbladder, appendix, those type of things going home
We
the same
we
day.
kind of had this evolution after it was during COVID. It is ironic because during COVID we couldn't do inpatient operations, and we used to do all these weight loss surgeries as inpatients. So during that time, Dr. Eggle, my partner, and I came up with some plans to try to make these at least certain patients who were safe for it outpatients. So we did 300 of them over that year and a half or so, kind of COVID time, because we could do them in the outpatient setting. We just couldn't do them as an inpatient. So we created these protocols where we did numbing blocks on their abdomen during the procedure that lasted for 3 days. We were really aggressive with the nausea and pain control before and after the operations. And then we started incorporating IV fluids kind of as a standard outpatient 2 or 3 days after surgery.
Hmm.
And so we incorporated these protocols. We did these 300 cases, and then we looked at the numbers and we said, huh, the outcomes are the same as they were when we did them as inpatients. They came back to the ER the same amount. The complications were the same. It's like, we should keep doing this because it doesn't make any sense to put them in the hospital if we can do them as outpatients. And so it was weird how COVID kind of forced that transition probably about 5 years faster than it may have happened otherwise.
Mhm.
And we actually went to a big conference and they presented a paper where they'd done 30 outpatient bariatric procedures. And we looked at each other across the table. We said, we had 300 of these and they're presenting this paper. It's kind of interesting. But then it's kind of transitioned that way. So a lot of people across the country now are doing lots of these bariatric outpatients. And it's just because they're easy to recover from. Patients do well afterwards.
That's amazing. That's really, really
That is
cool.
amazing.
We talked a lot about the different types of surgeries, how we decide. But one thing I don't think that we necessarily talk about enough, or depending on who you get referred to for the surgery, I know you guys do a great job of this, but I don't think it's discussed enough preparing for these type of surgeries. So kind of walk us through what a patient or a person could expect, in the weeks or months before having surgery to help prepare them for the best outcomes.
You bet. So most everybody comes in, these patients, they've been thinking about this for a long time, the majority of them, which is understandable. I think as you're coming into this, it's important to do your research. And I feel like talk to people who've had the surgery, find good sources on the internet, but find sources where they discuss the operations, the outcomes, the risks, the benefits. For us, for our patients, what I tell them is we do a seminar. We have it online. I say, just go look at that. We go through all the statistics. We talk about the good and the bad. But I think educate yourself first. And then if you decide to proceed with the operation, find a surgeon or find a center of excellence that you can go to where you can have a good outcome. So what a center of excellence is it's a institution. It's usually a hospital or a surgery center where they've been vetted by the boards, the national boards, and they have this accreditation. And so if they have that accreditation, they know what they're doing. You can't fake it. Trust me, it's kind of hard to get those things. So it's a lot of work. So go somewhere where they're vetted. They know what they're doing. The process at that point then is getting to know your surgeon, getting your questions answered, knowing what you need to do preoperatively. So there's usually a plan or some sort of preoperative stuff that you're going to have to do ahead of surgery. So for our patients, we have everybody do labs. We have everybody see a dietitian to prepare them for the diet before and after surgery. Everybody has to see a psychiatrist before the surgery. Now that's a standard protocol kind of across the country. But it's really primarily to make sure patients understand the decision they're making. And most insurance companies require that as well. So we have everybody do that. And then we also, in our practice, have everybody undergo what's called, well, Dr. Sorrell knows this very well, it's called an EGD or a scope, where we scope people. We look in the stomach and we look in the esophagus. Really, we're just screening for hiatal hernias, for significant Barrett's or reflux, H. pylori's, gastritis, those types of things. So we have people do that pre-op process. Takes about 4 to 6 to 8 weeks in our practice, depending on what all it is we have patients doing. Sometimes we'll have them do a little bit more if they have any heart history or any other pre-op workup we need to do from a safety perspective before the operation. And then right before surgery, we put everybody on a liquid diet for 2 weeks. So the liquid diet, it's kind of funny because we talk about all this stuff and the surgery and everything, and that's usually the thing that people are the most worried about. Like, they don't worry about the surgery, they're not cared about anything else. They don't want to worry about that liquid diet. The liquid diet is primarily to have people lose weight kind of rapidly right before the surgery. And the purpose of that is the volume or the size of the liver will get a little bit smaller during that time. And we got to lift the liver out of the way during the operation. And so for us, it's kind of it's purposeful, because the easier it is to see, the easier it is to get the liver out of the way, the faster we can do the surgery, less anesthesia we need, those types of things. But it also helps patients kind of get in the rhythm and the groove of it. And after about the third or fourth day, they're okay. But that first couple of days can be a little bit harder on them. But that's our process in our clinic. We have everybody kind of first educated, answer the questions. We meet them as an individual. We make a pre-op plan. We run through that pre-op plan. Takes about 6 to 8 weeks. Do the liquid diet 2 weeks ahead of time, and then we're at surgery.
Yeah, absolutely. And I've been to one of y'all's seminars. They're very good, very helpful.
Oh, thank you.
And I laugh because, I've been on some of these forums before where people talk about bariatric surgery, and the liquid diet is what they complain about the most. Like, literally, why do you only have to do 2 to 3 days? My surgeon's making me do 2 weeks.
See, and if you start making it uneven, then people start complaining. So we just kind of
It's kind of funny.
across the board.
One main thing people complain about. It's kind of hilarious. I mean, I feel the same. People do the same about colonoscopies, right? Like they don't care about anything else. You tell them
Of
they have to
course.
check clear liquids, and they're like, "What?
How dare
How
you?
dare you?"
Even when I tell people about the EGDs, that's the only thing they want to know is it the same as my colonoscopy? Do I have to do that? I'm like, no,
No, way
I
easier.
understand. You're exactly right. You're exactly right.
Complain about it. So.
Well, because you can't talk about surgery without talking about risk benefits, what are some of the most common surgical risks or complications you advise patient about when they're considering a weight loss surgery?
So the risks, and that's this is elective surgery. So if anybody's considering these operations, you've got to know about the risks. So for me and the patients, when we have our seminars, there's a couple of big ones that I like to discuss. The biggest risk that we worry about is what's called a leak. And so in any operation where you're involving stapling on the stomach or intestines or connecting intestines and stomach, you worry about those connections, those staple lines healing. And typically, if they're going to fail to heal, it's some sort of blood flow issue or something that's not allowing the nutrients to get there for them to heal. So in these surgeries, the risk of that happening, those leak rates are about 1% if this is kind of your first primary operation. You don't have any other risk factors, poorly controlled diabetes or any kind of immunosuppressant medication, any kind of operations in the region. If you don't have any of those other risk factors, risk of a leak about 1%. Okay, so that's not very common. We do a ton of these, so that's why I say to everybody we have us, I tell everybody this, because if you have it, it's 100% to you. You don't care that it's 1%. Now, if those were to occur, and those for surgeons, those are the ones we worry about the most. And I always tell people I've had a handful of those, and I can count them on my hands. Not very many, but I know all those patients very well. So we've worked with them, they've healed, they've done well. So even though it is the one I worry about, eventually they heal and they do fine. And some of those patients have actually been some of my most successful patients. But from a surgeon's perspective, that's the risk we worry about the most. Now, at 1%, yeah, it doesn't happen very frequently. And with the new robotic surgeries and the stapler we have, it's even better. The stress is even less because those complications are even fewer and farther between. Bleeding risk after the operation also is 1% or less. Significant bleeding requiring a transfusion or a second procedure. Those are the big ones. The more common things that we do work through that I tell people about are things more like reflux, heartburn, some nausea stuff they may work through. Typically, those types of symptoms, especially the nausea, vomiting type of symptoms, that may be common in the first week or two. It's unusual for that to be a persistent symptom long term. And so sometimes people have this preconceived notion that they're going to have some sort of chronic nausea, they're going to throw up all the time. If that is the case, something is wrong. If it's lasting outside that couple of weeks. So in that small week or two after surgery, yeah, that's something sometimes we have to kind of get used to that new anatomy, figure out how to eat, figure out the volume size. But outside of that, that should not be a chronic issue. Reflux is something we sometimes work through a little bit with the sleeves, especially. That's one of the reasons we screen for the hiatal hernias on the front end. So if someone has the hiatal hernia or the defect in their diaphragm where the stomach slips into the chest a little bit, we typically will fix those at the same operation as their weight loss surgery. And the reason we do that, even if they don't have reflux at the time, we will do that because you can imagine if your stomach's large and then we make it small, the pressure in there is going up. So we've kind of made a lower pressure system into a higher pressure system. So if you have a hiatal hernia at the top, it's going to tend to want to go backwards a little bit more with the sleeve. And so you may also have a little bit higher outflow pressure. So it may want to reflux more. So that's why we fix hiatal hernias with those. Usually the reflux kind of persists through about the first 6 to 9 months. And then as people are losing the weight, it improves. And most patients get off their reflux meds by about that time. Now, I've had about 10 to 12 who went the whole year. We had to kind of work on the reflux from an operative standpoint, but that's pretty rare as well. But those are the main things we've discussed. The bleeding, the leak rate, and the reflux are the common things.
I see a lot of these patients pre and post op, and you're absolutely right. And I wouldn't necessarily consider this next thing a complication, but a side effect, I would say, that people
Sure.
sometimes read about and get concerned about. So just, briefly mention about dumping syndrome afterwards, because that's one I usually see and get asked about a lot outside of reflux.
Sure. So dumping syndrome is much more common for bypass patients. You can see it in sleeve patients, but what dumping syndrome is, so people hear dumping syndrome and they think it's, oh, I eat and I gotta go run to the restroom. Okay. Now you may have a component of that. That may be a side effect of it as well. But really what dumping syndrome is if you take in too many carbohydrates at one time, and especially in a bypass. So in a bypass, that carbohydrate load would enter your pouch and then immediately enters your intestinal tract. So now you've got a large carbohydrate load in your intestinal tract. The first thing that happens is the fluid volume in your intravascular volume gets pulled into that intraluminal space of your intestines. So you have a little bit of a blood pressure drop. And then your insulin spikes and your blood sugar falls. So you kind of have this simultaneous blood pressure fall, blood sugar falls, and people basically feel like they're dying. They feel miserable. If you ever see somebody do this, they do it one time and they never do it again. They eat that one donut. They're like, I'm not ever doing that again. Now you may still have some loose stools and stuff after the fact, but that's true dumping syndrome, and that's much more common with the bypass. Now sometimes you can have some rapid GI emptying, especially with certain foods, and that's just something that's kind of a learning process, and that's true of all the diet as you go through these things, because we're changing your anatomy of your GI tract, both the sides of your stomach, maybe the way your intestinal absorption occurs. So the way maybe bread hits you, or the way that milk products affects you, or it may be different. And so sometimes it's just a matter of trial and error, letting patients kind of work through that,
Mm.
and they do, and they work through it, and they usually find one or two things that they just don't care for anymore. Sometimes they'll find a couple things that they didn't like before that they just love now. Um, but those kind of things they kind of just work through normally. That's just a progression that just happens. But the dumping syndrome is more of a, oops, I shouldn't have done that, but I'm not ever going to do that again type of deal.
Yeah, and the diet modification is such an important part because, with a smaller, I say, receptacle area for you to take food in, what you put in becomes really important as well. And one of the things I always have to try to counsel people on is, protein, for example, afterwards. A lot of people try to avoid those type of things because, they might be more filling, so they don't get to eat as much, for example. But, some of the complications or side effects that sometimes people complain about, like hair loss and, fatigue and muscle loss and stuff. Well, a lot of that is because you have to do that diet modification afterwards, not just to prevent dumping syndrome, but to stay healthy, because you got to make better choices when you can't eat a whole lot, right? Because you can't make up for it later. And I feel like that's really an important part to emphasize. And I remember distinctly having a patient who had liver disease, and I talked to him about this surgery because I did that a lot. And it fascinated me because she had diabetes. She had some other comorbidities, and it was funny because she was like, "Oh, I'm not having that surgery because I'm going to be on lifelong supplements and being malnourished." And I'm sitting here thinking,
Mm-hmm.
like, you're on lifelong diabetes medication and blood pressure medication. It just kind of it baffled me that people are more concerned about potentially having to take vitamins afterwards than necessarily
Yeah,
medication. So it's just in general so that people are kind of aware of, what kind of, supplements or things you usually see afterwards, outside of maybe the immediate post-op period.
sure. No, that's a great point. That's a funny point, actually. Yeah, actually, it reminds it. I'll answer your question. So I had this people had this preconceived notion, like on the diet side. Like I had a guy one time in seminar. He asked me, he said, and he was very serious. He goes, after this surgery, I'm going to be on liquids the rest of my life, right? And I was like, you mean you think you're going to be drinking liquids from now on? He goes, yeah, that's what we do, right? I was like,
Oh no.
no. I was like, who would ever do this? I was like, that's nuts. So from a diet perspective, really the main thing that changes is just the amount that you could eat, probably. Okay, now you're right, absolutely, that we want to focus on protein because one, we can't take in the amount we did before, so we want to get the healthy calories in first. So we want to get protein goals in first. We try to get about 60 to 80 grams of protein a day, and we really lean on our dietitian to guide our patients on that aspect. But you can still, after the surgery, we do liquids for a little bit, then we do soft foods, but eventually, after a few weeks, 6 to 8 weeks, you can have regular food. So you're eating normal food like you do now, You can have dinner with your family. You're just not going to be able to eat as much. And so it's a circumstance where I usually tell patients you're probably going to have to eat 4 or 5 times a day just to get what you need in, because you can't do it at 2 or 3 settings. But sometimes that's beneficial because it actually is helpful for your metabolism. It helps maintain your blood sugar more evenly if you're kind of eating that way, as long as it's planned. That's what me and my dietitian used to get into all the time. She's like, well, if you let them do that, they're going to start grazing and they're just eating all day. I said, that's not what I said. I said, we have 4 or 5 meals, but you got to plan them. Just like you had lunch planned, your afternoon snack is a planned thing. On the vitamins, it's pretty simple for us. I just tell patients, just take a multivitamin daily and just be consistent with it. And then we just check our patients' vitamins once a year. And so I always check them before surgery, kind of see where we are. We do them at 3 months so we can make sure we're doing well, keeping up, we're not falling behind somewhere. And then we check them yearly after that. And everybody does very well with that. If they fall a little bit behind supplemental wise, we just supplement, the vitamins, calciums, the irons, the same things that other people would be deficient in. But I think as long as they're consistent with just a daily multivitamin, it's pretty simple. It's not too complex. And that's even for the bypass patients or the switch patients. Now, there is a little more of a demand on those patients, and we have to focus a little bit more, sometimes on the thiamines or the calciums or the irons. But as long as we're following them, as we should be once a year, at least checking some labs, and they're consistently taking those, it's not too big a deal. But you're right, it's comparative to taking insulin and everything else that they'd be taking before the weight loss surgery. It's kind of interesting that some people would be concerned about that, but it's an interesting perspective that people do have. They definitely think that way sometimes.
Absolutely. And I love the point that you make about follow up, because that's one of the things I don't see a lot of, and why it's really important when you decide who your surgeon's going to be, because you do need to follow up with them, for at least a few years after surgery until, it can be maintained by, a good, primary care physician, for example. But a lot of times when people, try to look for maybe like I don't want to say the cheapest option, but if that's what they look at, or they travel really far away. It's
They go to Mexico option.
Yeah, exactly.
I've seen that made too many options.
I was like, you gotta have someone to follow with, because it's important, and if you don't, like, I can see you in clinic, but I'm not a surgeon. And so it's really hard to help address some of these issues that are going to happen for the several years afterwards if you don't make a good choice in that.
Of course, yeah.
Absolutely fantastic. Thank you for this really, truly invaluable insight. We are going to go ahead and switch gears to a new topic that has not been discussed on this show before, but is very, very prevalent. Cari, do you want to take us off on topic 2?
Do you snore at night? Better yet, most importantly, does your bed partner snore at night? Do you know someone who maybe shakes the walls with their loud snoring?
I do know someone for all of these.
Yes. Well, they may have a condition called obstructive sleep apnea.
Now, okay, snoring alone is not what we're talking about. We're actually talking about something that's a little more complicated. Snoring alone doesn't mean you have sleep apnea. A person can have snoring for a multitude of reasons, ranging from, a nasal septal defect to, the nasal congestion with a cold, or if you're like me, the vascular change that happens when you're pregnant, and then all of a sudden you're like, why am I snoring? That's crazy. But it is something that you need to consider, and we are going to discuss quickly today who's at risk for a serious condition called obstructive sleep apnea and when to seek out that medical advice.
So from now on, I'm going to refer to this as OSA, because I'm getting tired of saying obstructive sleep apnea. But it's a disorder that's characterized by obstructive apneas or hypoapneas, or basically a respiratory side effect arousal issue. So basically what that means is there's a partial or complete collapse of your airway, while you're sleeping, that causes you to obstruct temporarily. And that's the layman term for it. And so when that happens, your oxygen level actually decreases, usually to a point where it's not sufficient enough to oxygenate your vital organs like your brain. And a lot of times that's what causes you to wake up, because your body's going, hey, I need some more oxygen. You need to wake up, stop this obstruction so we can breathe. And it occurs in about roughly 15 to 30% of men and about 15% of women.
So let's break down what's actually happening. So the throat is surrounded by muscles that control the airway for things like speaking, swallowing, breathing. These muscles hang from the skull and the jaw and surround a very flexible tube, right? The main airway that brings air into the lungs. During sleep, these muscles are just naturally less active because you're relaxed, which can cause the throat and this airway to narrow. In most people, this narrowing doesn't affect their breathing while they're sleeping, but in others, it can cause things like that snoring sound, sometimes with that reduced or completely blocked airflow. A completely blocked airway without air is called obstructive sleep apnea, And that partial obstruction with diminished airflow is called a hypopnea. A person who has both can have apnea and hypopnea. So this insufficient breathing due to this effect results in falling oxygen levels and rising carbon dioxide levels in the body. Because that airway is blocked, breathing faster or harder doesn't happen like you would if you're exercising or short of breath, like with, maybe like an asthma attack, you're breathing faster and harder. Well, it doesn't really happen when you're sleeping like that, because that's not able to improve those oxygen levels. So the obstruction causes the sleeping person to actually just briefly awaken and try to activate those upper airway muscles to open up and get more oxygen in. Once the airway is open, the person then takes several deep breaths to try to catch up on that breathing, and then they fall back asleep. They may move a little bit. They may snort. They may make a loud snoring noise. Less frequently, a person may actually awaken completely with a sensation of kind of gasping or smothering or choking sensation. If the person falls back to sleep quickly, which oftentimes they do, they don't remember that this happened whatsoever. And so you may see a bed partner or somebody make all these noises and sound terrifying, like someone's smothering them in their sleep, and then they fall right back to sleep. Many people are completely unaware that they're abnormal breathing in their sleep, and they underestimate how often that their sleep is interrupted. They may say, oh, I get pretty good sleep. I might wake up a little bit. But if we put them and actually do the study, they don't realize it's a crazy amount of times that this is actually happening to them each hour. A lot of times it makes them feel like their sleep is not refreshing and produces this sense of fatigue and really just sleepiness throughout the day. Some patients have sleep apnea because of small upper airway. And I found this to be really interesting. The bones of the face and the skull develop. Some people develop a smaller lower face, a smaller mouth and tongue that seems too large for the mouth. These features are largely genetically determined. So it's the reason why you may have family members who have sleep apnea. And you're like, I have a lot of my patients are like, well, I'm talking that they're maybe at risk for it. They're like, well, my mom, my dad, my brother, my sister, my aunt, my uncle, my grandma, they all have this. Well, it may be genetically determined more because of how the facial structure passes on with those genetics, which I think is really, really interesting.
Yeah, absolutely. And there's some other risk factors besides just the anatomy things that you mentioned. So age is one of them. Of course, it can happen at any age, but the older you get, middle-aged, older adults are more at risk. We talked about this number, but males are at higher risk. They're twice as common as females, especially when you talk about middle-aged or those who are on hormone replacement. Obesity, of course, is a risk, and one of the things you can see improvement with weight loss surgery is obstructive sleep apnea. So obesity, sedation. If you're on medication that makes you sleepier, or you drink a lot before bed, that can also put you at higher risk because again, it reduces breathing and potentially prevents you awakening during the night. So it can sometimes lengthen those periods of apnea with sometimes dangerous consequences. And then of course the anatomy issues that you mentioned.
Yeah, and even things like large tonsils. We talk about that in children oftentimes too. If you hear your child with this loud snoring, or if you do notice some of that awakening when they're sleeping, that snorting noises, it's a great time to take them to the ENT and look at those tonsils as well.
Oh yeah, we've done that.
So most patients with sleep apnea complain of daytime sleepiness, or maybe their bed partner reports loud snoring, gasping, choking, snorting, interruptions in the sleep like we talked about before. But there are a lot of other symptoms that are attributable as well. And these are the ones I bring up with my patients a lot. Yes, the not feeling well rested after sleep and fatigue. And I tell patients, I actually don't really care how well you sleep. Sometimes that's not the most important thing we're looking for. But there could be things like awakening with that choking or gasping, nocturnal restlessness, where you may think, oh, I might have, restless leg syndrome. Well, you may not actually have restless leg syndrome, and maybe this restlessness that you're feeling has to be more due to the oxygenation issue. Insomnia, difficulty initiating sleep, maintaining sleep, or frequent awakenings can be related to this. But one that really I talk to patients about is things like lack of concentration during the day, ADHD-like symptoms, cognitive deficits like short-term memory loss. I had a sweet patient one time. He was about 65, and he swore to me that he's going downhill. Everything's terrible. He's got dementia. He knows it. Like his life is over. Like put him in a nursing home. And he's kept talking. And I realized you don't have dementia. You have sleep apnea. We treated him, got him taken care of. He came back in a couple months later and told me that he as a whole new person. He feels better than he did when he was at 40 years old. His wife thinks that she married a new man because of all this energy he has. So there's a lot of things that people don't think about like that. Things like morning headaches, changes in mood, including depression and anxiety, vivid, strange, or threatening dreams is one that I thought was always really interesting. Nocturia, meaning needing to wake up to use the restroom more often during the middle of the night as well to urinate. So those are other things just to kind of keep in mind. But of course, examination findings when we have a patient that's at risk for this, obesity, some of those changes in the oropharynx of the mouth and the throat we were talking about as well. We talk often about neck size, how big their neck size is. And some of our men know maybe what size their neck is from wearing like a tie or shirt. And so there's some certain cutoffs that you may want to talk with your primary care physician or sleep specialist about.
It is really important because complications of untreated sleep apnea can be serious. You mentioned when you've got things like reduced alertness, difficulty concentrating, sleepiness, you can have car accidents or other type of accidents because of that. Studies have shown that people with severe OSA are more than twice as likely to be involved in a motor vehicle accident. So that's no small statistic. People with OSA are also encouraged to recognize this risk when discussing options for work. So if you are going to have to drive for a living, for example,
Our truck drivers,
you
Mm-hmm.
need to make sure that your employer, is aware of these things. In addition, people with untreated OSA may have an increased risk, of course, of heart disease, high blood pressure, heart attacks, and stroke. So again, treating it is very important to prevent these risks.
We recommend, diagnostic testing in patients who have excessive daytime sleepiness, that habitually loud snoring, not just like it happens for, the week you're sick, but continuous. Witness apneic events where, your bed partner says, hey, you stop breathing for a second and it's terrifying, or that gasping and choking during sleep. For a patient at risk, we recommend a sleep study. It's really not, it's not invasive. It's easy to do. It's done at nighttime. You don't have to try to sleep during the day. There are actually home sleep studies that can be done as well. And these sleep studies measure the breathing effort and airflow, your blood oxygen level, heart rate, rhythm, all these great things that really tell us how you're sleeping and what risk that you have for sleep apnea.
Yeah, and if you are concerned about yourself or a loved one, like I said, a lot of times it's your partner that identifies these. Make sure you seek out medical advice, like you mentioned, from your primary care doctor or sleep specialist. It's easy to diagnose, and getting treatment can be life-changing.
Thank you guys so much again for joining us today. Thank you, Dr. Purtell, and all your helpful insight. I learned a lot too as a primary care physician. I can't wait to apply some of this to what we're doing. Don't forget, if you're a listener claiming your CME credit, please look in the show notes for those instructions. And then again, for all of our listeners, thank you for tuning in. Please like, please subscribe, follow us on all the socials, and share this episode. Let us know what other topics you're interested in through our Instagram or our TikTok, and stay tuned for our next episode.
We wish you all a great 2025.
Happy New Year.
Thank you for listening to the MedEdit podcast. Please click the follow button to be notified when new episodes become available. For more information about this episode, and to learn how you can reach Dr. Cari Sorrell and Dr. Jessica Gray, please visit today's show notes. And don't forget, click that follow button to be notified when new episodes become available. The information and content has been made available for informational and educational purposes only, and does not constitute a physician-patient relationship. If you need medical advice or help, contact your personal physician. The views and opinions of the guests do not necessarily represent the views or opinions of Dr. Jessica Gray and Dr. Cari Sorrell. This podcast should not be considered as an alternative for medical advice, diagnosis, or confirmation of an illness or disease. Please seek assistance from your personal health practitioner.